polyamides were born, if I'm not mistaken, in 1953, when two Hungarian brothers, being in the United States, they immigrated, they were fishing, they were looking at that line that they use for fishing, and they said, why don't we use this material to make dentures? Pink dentures. And so we use this type of material even today. It's not very easy to make such a denture. It's not something that you would use as the first option, but you have to take it into consideration because there's a lot of advantages. First, polyamides don't affect the enamel of the teeth. They are photomimetic, so they have an excellent aesthetics. And here is where we could use them. So just to have an idea of what the clinical indications would be, you could replace a classical denture, acrylic denture with wire clasps, because those clasps are non-aesthetic. You can do this when the dentist or the technician or both, they don't have enough experience to do a removable denture with special attachments, right? Which is quite demanding. So this one is definitely simpler than the one with attachments. Then patients who have jobs that in which they could sustain physical trauma. Yeah, so you don't want to have metal in the mouth because, I don't know, I mean, policemen or, you know, people who work with animals or something, so you don't want metal in the mouth, yeah, because the physical trauma could be a problem if that metal hits some parts of the palate. So this is flexible. This is very sure in case of trauma. Then the elderly patients, including those who cannot be taken by their families, you know, to the office, to the dental office. So you can do that at home. You take an impression, you do the denture. You can allow the patient to stay home if the patient cannot move from home, yeah, cannot come to the office. And also they can be done as a temporary solution for the cases in which later on you want to just to place an implant. Now, there are also disadvantages of the polyamides. It's the fact that there is no chemical adhesion between the teeth and the base of the denture. What you see in the image is a polyamide. So this is like a continual clasp, arrest on the palatal aspect of the upper teeth. So the patient had all the teeth from canine to canine on the upper jaw. And those are the injection sprues. So what is the disadvantage of this? As we said, the lack of chemical adhesion between this and the base of the denture, which means that the teeth need to have some Y-shaped tunnels drilled inside of those teeth, so that the polyamide, the nylon, when it gets pressed there under heat, may get into those tunnels and actually create a continuous mechanical retention, like a sewing. Yeah, it's very important for me because as a dentist, because the first tooth here, so neighboring the last natural tooth, I have to know that there I have this retention. Yeah, and many times the dentist is just trimming a little bit from there because he feels that the denture doesn't go perfectly. But I have to know that I have to do it very carefully, because if I trim too much and I cut that retention, that this tooth will be removed during mastication. So very carefully there. Otherwise, myself as a dentist, I don't need to trim from this denture. In principle, yeah, there may be other cases, but there is a very important point, because there I have a retention. I have to remember this. Second problem of the polyamide is that you need a more rigorous hygiene than normal acrylic, because the material absorbs water, and not only water. Yeah, so water absorption is a problem, and not only water, that's what I was saying. So you have to clean it in a special substance. That is something going on with oxygen and peroxides and things like that. There's a special substance to clean it. Yeah, the patient is taught to create such a liquid, adding the substance to some 250 milliliters of water, and that substance will last for 7 days. And each evening the patient places the denture there for 15 minutes. That's the idea. And then after 7 days, the substance, the water, the cleaning liquid is changed. And the other problem is that to rebase is very difficult. You better do another denture than to rebase an old one, right? You better do it all over again. So it's not easy at all, because you have to inject something heated over this one that has to be reheated. It's so difficult that you better do another one. So this is a clinical case. This was in the maxillary. The patient needed to go to France in 1 week. So you see those two metal ceramic restorations are, just like, minimal, just to place some canines there. They had to be restored. Those canines had to be restored. It's not aesthetic. It's just to do it quickly in 1 week. Yeah, because afterwards we place the dentures, and that's how it looks, which is fairly okay. For, you see the clasps here, they are not bad, better than metal clasps for sure. And so we treated the teeth just because the canines needed to be treated. They needed crowns, right? If those teeth were healthy, we could have done the denture without touching the teeth, right? You see the beauty of this polyamide, which is very photomimetic. You would believe it's a real gum. If you don't look carefully, if you don't look with much attention, you may. Socially, it's very acceptable. Much better than metal clasps. Another case. This patient is not alive anymore. She had cancer, so she needed something. For a period of time, she did wear this denture for 2 years maybe before she passed away. So it had to be, nice looking and without big interventions. You see also the clasp is going away from the gum. We don't want to create more recess at the gum level than it's already there. This is a little bit of a cheminy, what we call it, a partial one-quadrant denture. This is a composite tooth, and this is a molar, and this is the canine from the removable denture. So this is unilateral, so to say it. It's a combination. You see the teeth that are missing, canine and first premolar. Second premolar is a composite, and then first molar belongs to the denture, to the removable denture, and then we have also in the back a metal second molar. We should have maybe trimmed a little bit more carefully there. Yeah, always the picture tells you exactly where you made some mistakes. This is another clinical case. It's a very good friend of mine. he has an implant now here, but before he had this, we just helped him quickly with such a small denture. You see, the clasp is quite short. It's just what he needs to have this on place. And normally, well, nobody could guess that he had the problem there, right? The only thing was that sometimes he would forget that in the bathroom in the morning, and then he would just wander in the city without the tooth. And one time he had it, one time he didn't. So, but finally now he has an implant. So the problem is that the master model has to be foiled with wax in order to have the final denture at a distance from the gum. This is highly important. So if the technician doesn't know that he has to do that and how to do it, then it's a disaster. It destroys the periodontium. It destroys the remaining teeth. Yeah. Also, those zones in which the bone is very close to the tissue is very thin. You have to foil it with wax. And obviously then you duplicate this model, right? And you inject the denture on this model after it has been duplicated. So then you have these spaces free, so to say, at a distance, right? And this information has to be given by the dentist to the technician by marking it on the impression. If you don't know that, if patients don't receive dentures done in this way, it's a problem. It's a mess. It's a real mess, because the denture is free to press on the gingival margin and will actually destroy the marginal periodontium. So this can be a good solution for patients who want something fair, aesthetic, quite aesthetic, functional, obviously, without major interventions on their teeth. Or for dentists who are not, so to say, able, they are not good enough they don't know how to do better dentures. So that could be a very, very good aesthetic and quite simple solution, again, for the dentist, because for the technician it's not that easy, but it can be done. Now, the big problem of those dentures is that they sink into the gingiva, right? And in 2012 I published an article in which I demonstrated how this can be solved. The denture is maintained by the clasps, this is sure, but the problem is how you prevent it from sinking into the gum. Next to the pillars, to the teeth pillars, that's the question, that's the problem. So I did more than 80 dentures like this, maybe 100. So I got quite enough experience. The idea is very simple. You see, those are two united crowns. Here is ceramic to allow the papilla to grow nicely. And what we see here is like the front of a boat. You could call it like this. Yeah. It's not very academic, but you can call it a proximal rest. Yeah, and it's placed at the cervical region, so cervical proximal rest. And this is an MOD. This is like an inlay extended with such a rest. You see, here is sandblasted because we want it to be fixed in the tooth, in that case a canine, and then the very, very polished part that goes in contact with the gum, right? So this is the oral aspect. This is how the tongue will fill it. And see, this is the case. This is the canine that would have to receive that MOD, that inlay, that has the rest added on the distal. So it's a special preparation here, 0 degrees preparation. It's a very special technique. Well, it was special in like 12 years ago, 15 years ago. which I published maybe I think in 2008 already. So it's quite old stuff. It's well known now, especially in my country. And here you have the two abutments on which that those crowns, united crowns, would be cemented. So the rest would be one on this side and one on the other side. So here they are. Yeah, see, one of the rest is here, the crowns, and the other is the canine with that inlay cemented, and there, as you can see here, is the rest. So this is an anti-sinking, so to say, device. At that time, I started thinking maybe we can do it in zirconia. I don't know. Never tried that. Never tried that because now we do many implants, so this type of denture is not used anymore. Maybe, I mean, much less than before, way less than before. There's also the option with telescopes. So, but anyhow, so this is what you can do with polyamides. So this is the impression, and then the denture. See the clasp here? It's static. You can see here the foiling. You can see the distance. Yeah, from this angle you don't see it, but from the other one you do. That the denture is at a distance from the gum, so as not to press on the gum, because you will have recessions. And the denture will sit there without sinking next to the natural remaining teeth. Yeah, on the distal it does, but that's something that you cannot avoid. But here, in order to avoid sinking next to the natural remaining teeth. So you see the remaining teeth, they are not very happy either. But that was okay for the moment, and the patient did wear this for, I think, for 5 or 6 years, and then we had to change for an overdenture.